Thank you very much for allowing me to talk a little bit about my work here today. I understand from Anais that you have started recently a program in Zimbabwe, and I think you'll find some of the things I'll be talking about may in some ways be very familiar, because the situation in terms of international aid and global health in Haiti is very much parallel to what's happening in sub-Saharan Africa, where a lot of resources and partnerships in global health have been developing. So I'm going to be talking today trying to make some links between international medical interventions and global health education as it's showing up here in North America. So as you're aware, global health has become increasingly popular in North American medical schools in the last 2 decades, I would say. And really, there's been a dramatic increase in the number of programs and possibilities available. So I'm currently doing a 2-year postdoc at UCSF and UC Berkeley in their joint program in medical anthropology. And my doctoral research was on international medical aid in Haiti. So I'll start by talking a little bit about that. This was a photo that I took at the hospital where I did most of my field work. And I find it an interesting photograph because there's so much going on. The physician here in the white coat is from an American NGO that's in partnership with this hospital. And he's giving a tour of this hospital for 2 visiting physicians here in the light blue shirt, and the woman here with her hands behind her back. They are from Nepal, and they were in Haiti with Nepalese soldiers as part of a UN stabilization mission. And this mission became really infamous because they are identified as having been the source of the massive cholera outbreak that started in Haiti in October of 2010. The base where the Nepalese battalion was located was dumping refuse into the nearby river, which is one of the most important rivers in Haiti, and a lot of people are using it for drinking, bathing, everyday use. And the strains of cholera were traced back to an epidemic that had just taken place in Nepal. This was about a year before that, and these physicians, because they were only in Haiti for 6 months, had gone home, so they were not involved in the drama that would come later. But the American physician had run into these 2 doctors who didn't have much to do because they were essentially responsible for a group of young, healthy men. And so he said, well, would you be interested in helping out at the hospital? You know, we could use your help, we could use your services. And so he's giving them a tour here. Now, what's interesting is that the hospital administrators, the directors and the people actually kind of running the hospital are not present. They kind of outsource the tour to their American partner. So the executive director and the administrator weren't even along for the tour. However, you did have 2 Haitian medical residents, who are the man standing in the background. And they were senior residents in surgery and internal medicine. They spoke pretty good English, and they were both interested in leaving the country. And so I'll be talking about this a little bit later in terms of international intervention and the bridges that develop between Haitian health professionals and groups from the outside. Over here you have nursing students and nurses who are not at all involved in the tour and were not at all asked about their work or their conditions. You also have some medical equipment from my hometown of Montreal that was donated here, broken and never got fixed and took up room for a couple of years and eventually got thrown out. So this picture highlights some of the dynamics, international dynamics that are present in Haiti's health landscape. Just in terms of location, Haiti is very close to the United States, about an hour-and-a-half flight from Florida. It's the most densely populated country in the Western Hemisphere, so it's at now about 9 million people for a country the size of the state of Maryland. And then looking at it a little bit closer, most people in Haiti actually live along the coast in the coastal cities. And this is some basic information. Some of this may sound familiar. Actually, I'm sorry, I made a mistake with the population. They're probably almost up to about 10 million now, but there's not a lot of reliable census information from Haiti, so these are estimates usually built on prior numbers. Life expectancy is very low at around 62 years, and very high infant mortality. You also have a lot of preventable diseases, diarrheal diseases, malnutrition, malaria, tuberculosis. One piece of good news, however, from Haiti is that the HIV rate has steadily been going down after holding at about 5% for over 20 years. Now we've seen some major decreases. So it's still the highest national rate in the Americas, but at a little bit under 2%, that's quite a bit of progress. Those of you who are familiar with Partners in Health and Paul Farmer's work, that is mostly in the Central Plateau, and then in this area here by the coast, but kind of the middle swath of the country. And most of my fieldwork has been up along the north coast in the city of Cap-Haïtien, which is the second biggest city, and then in rural areas surrounding it. I won't go into these numbers in details, but they're important in the sense that we know a lot more about Haiti's patients in terms of the demographic numbers that I've just presented than we do about health workers there. It was in 2007 that you had the first complete census of health workers in Haiti, and this was really going to all of the clinics, hospitals, dispensaries to get a sense of who was there in healthcare. Nurses, community health workers, dentists, midwives. And so you can see a breakdown here. Some of the things that come out of these numbers is that you have a rate of 2.6 health workers per 1,000 individuals. And this looks all right at first glance, but a large percentage of them are support and administrative staff. So you have people who are doing clerical work, drivers, janitors, cooks, who are making up a disproportionately large number of the health workers. You've got about a third who have university level training and a little bit less than that who are in a position to provide autonomous care.
What is the rate per 1,000 individuals in the United States?
Actually, I don't know the US rate. I'm assuming it would be significantly higher. The highest rate in the Americas is Cuba, and they're actually able to export doctors who go on mission and rotations to places like Haiti. The WHO recommends, in terms of physicians and nurses, that there be 2.5 per 1,000 individuals. And in Haiti, it's 0.59, so significantly less than what's considered necessary to provide just a basic primary care, basic vaccination coverage, prenatal, and kind of a basic package of health services. The health workers are also quite young, which is interesting. 2/3 of them are under the age of 45, and they're also concentrated in the capital of Port-au-Prince. And this is a problem not just in Haiti, but in a lot of countries where physicians, nurses want to be working in areas, for example, where their kids can go to good schools, where they have access to stable infrastructure, things like electricity, running water. And you've got very few who are in primary care facilities. About half are in hospital, but about 18% of Haiti's health workers are accessible really to people who have very pressing health needs. So in terms of the hospital where I did my field work, this is a painting of it from the 1940s. This hospital was actually built by and kind of funded by wealthy Haitians in the town of Cap-Haïtien. I think this is something that gets forgotten a lot, that Haiti's elite was very involved in its medicine throughout its history. So this was actually the postmaster of the city who had the hospital built, and the first thing that they did when they were planning it was they got in touch with a community of French nuns, because nuns are really good at running hospitals. They have a very fixed hierarchy, they keep very good records, and oftentimes they have access to resources like land, or they're able to solicit donations, either from other religious groups or other aid groups. I found a plaque actually on this wing, which is now surgery, from 1925 when Haiti was under the American occupation, saying that the surgery wing was a gift from the American Red Cross. So when the hospital was founded in the 1890s, already you have French nuns doing administration, you have the American Red Cross in the 1920s, and then subsequent groups who have been coming in over the decades. So this is just to illustrate that international intervention in Haiti and in its health sector specifically is not something new. We heard a lot more about it during and after the earthquake, but it's something that's been going on for a long period of time. I asked an artist to produce a painting of the hospital today, and this is what he came up with. It's accurate in that it's a much busier place than it used to be. It's about a 250-bed hospital, and it's got a catchment area of about 1 million patients. So people are coming from pretty far away to get to this hospital. And when I started my research, I knew of 5 international organizations that were active there, and I thought I'll find another 5 or 6. By the time I left, I had counted 37 international groups in government that were present in this hospital, either giving materials, sending personnel, sending vaccines, doing trainings. The groups and governments are involved at different levels and with a different scope, but this was even before the earthquake, and then after the earthquake, that number went significantly up, initially for relief services, and then new partnerships that came out of that initial contact after the quake. So this is the internal medicine wing. You can see actually has lovely historic architecture, again from the late 1800s, based on a French hospital model. The nuns used to live up there, and then the patient wings were down here. The nuns left in the early 1990s, and this is a phenomenon that's taking place not just in Haiti, but also in Latin America and other parts of the world, in Africa and in Asia, with the aging of Catholic religious communities. So a lot of these establishments would be staffed by nuns and priests who would go to them for 30, 40 years, and sometimes even longer. And throughout Haiti, you still find a lot of French Canadians and a lot of Americans, I shouldn't say a lot, I'm sorry, a dwindling number. And they're in their 70s and 80s, and many of them are passing away in Haiti, or they're returning home so that they can be looked after in their communities. This was a departure ceremony for a group of British nuns who had been at this hospital for many decades, and it was being turned over to a Haitian staff. What happens a lot of times in these instances is that the partnerships that these communities have been able to develop, oftentimes they do not last after the religious community leaves. So for example, I was at another clinic where it was a Canadian nun who had been there, who used to regularly get a visit from the Canadian ambassador, who would also make sure that she got some donations and funding. And within a year after she had left, the clinic had practically fallen apart, and the people in charge of it said, no one comes to see us anymore. We've tried to reach out to them. They're not interested. They were only here because she was here and she was Canadian. So this is a transfer that's happening in many places, and that is going to have big impacts in terms of these institutions that have been serving populations for decades, and now are going to be struggling to maintain their partnerships. This isn't the greatest picture, but I wanted to make a comparison with this building here, which you can see is starting to be in pretty bad shape. It didn't have running water or electricity, and it housed nursing and orthopedics, and then you have the OR here on the right. Haitian health professionals are in a dilemma in terms of trying to attract international aid. I asked about these services and why they were in such rough shape, and a nurse who worked in them says, you know, I think they're intentionally letting them get run down so somebody will come by, be shocked, tear it down, and rebuild it. So the idea is that if they did some improvements to it, people might not recognize the need that was behind it. And this showed up in a very concrete way in the ophthalmology service, which was actually with ENT and ORL, but this was kind of a shadow service in this hospital. I never met anybody who worked in it. Ophthalmology is where it was happening. We had a very charismatic director for this service, and she was very good at recruiting aid. She'd gotten from the Lions Club and from some other sources a lot of support. So she had her own operating facility. She had a regular supply of eyeglasses coming in. She'd done a fresh coat of paint for the service, had it secured with metal bars. But this created a problem for her. So she said that people would come by the service and say, you're doing great. Everything looks really good. You don't need us. And then they would leave and go to another part of the hospital. But the fact that the service was in good shape had attracted more and more patients. So she was trying to do more outreach, trying to do mobile clinics. She wanted to expand, but she was having a hard time getting aid because people would come and see what it looked like and then say, oh, we need to go someplace that needs more help. So that's why the other nurse had suspected that they were letting the orthopedics wing really fall to pieces as a strategy to recruit assistance from the outside. And so this was in 2008, and the director of ophthalmology was wondering how she was going to keep going. And her predictions came true when I went this year in 2013. And already you can see that things have deteriorated for the service, with the paint not being in great shape, some of the crumbling. And some of this is just cosmetic, but on the inside it shows as well. The equipment that was so new, the supplies that were in large amounts, all of this has diminished. And so you have this interesting cycle where people are going to be in need for periods, and then they'll get support, and then they'll lose that support, and then they'll go into need again. And this creates a lot of instability. It also creates certain relationships between clinicians in these places and the funders or partners that they're hoping to attract. So Haitian clinicians are not only required to perform need in their interactions with foreigners, they also need to perform reliability. So the woman in the foreground with the bag from Target asked me to take the photograph. She said, take a picture so they know that I really gave out what I was supposed to give out. She had received safe birthing kits from a group in the United States that had gloves and gauze and some sterile cord to tie off the umbilical cord and a razor blade. And because Haitian clinicians are often suspected of diverting aid or of reselling it or of being unscrupulous with it, they will often take measures to show that they are reliable conduits, to say what you're giving us is actually going to patients. We're not going to be diverting it. So you also have a nurse in the background with the red and white striped shirt, and they really wanted this picture to be taken, not so much to commemorate the event for sentimental reasons, but to be able to show donors that they were indeed doing what they had been asked to do. One of the problems that Haiti is facing, I mentioned this earlier, and other parts of the world as well, is that its clinicians are leaving in really massive numbers. It's estimated that about 85% of clinicians trained in Haiti are leaving the country. And they are going to the United States, to a lesser extent to Canada and France. Some of them will go to the Dominican Republic as well, but the US is really the favored destination. And they will do this oftentimes with starting off with training opportunities. So this was a departure party for this resident here in the pink tank top who had gotten a scholarship to go study in France for a period of 2 years and had to sign a contract that she was going to return. And there are different ways that groups deal with this training as a stepping stone for departure. Some of them ask for, like in this case, a contractual signature saying that we will I will return to Haiti to practice for this period of time after I come back from the country. However, how these actually get enforced and how it's possible to make sure that the person does come back is quite difficult. Again, this is something that's been going on for quite a long time. I was telling Anais that I spent some time in Stanford's special collections in the library today. They have the archives of the sister of the first female doctor in Haiti. So the first female physician in Haiti was at OBGYN in the 1940s, and her sister's papers are all here at the library. So I went and had a look at those, and what was interesting is that even back then, the 1940s, the sister, after finishing her medical training in Haiti, went to Brooklyn, went to Chicago, and went to the University of Michigan. And it talks about this in the article, saying, oh, you know, we're hosting her here so that she can go back and teach other physicians in Haiti the skills that she's learning in the United States. So again, this has been a process that's been happening for a long time. The differences are now that when people train abroad, they tend to not go back to Haiti when they're finished. They tend to emigrate. A lot of times they will lose occupational status after their migration. So in the hospital where I was working, an OBGYN who landed in Montreal could not find any work other than moving boxes in a warehouse. And he's still doing that 3 years later. This is a typical story for a lot of migrants who are coming to North America, that they take a significant kind of cut in their working status and their occupational status. So you meet folks in Montreal, for example, taxi drivers who are engineers, or someone like this who is doing manual labor. A lot of them will stay in the medical realm, working as orderlies in hospitals or physician's assistants. And they know that the risk is there. But out of all of the residents that I interviewed, 52 of them at this hospital, only 2 of them said that they intended to stay in Haiti after they finished their residency. So at the same time that you have the aspirations of young Haitian clinicians who wish to go abroad, you also have an increasing desire on the part of universities and global health foundations to keep these people in the countries where they're working, and creating different incentives so that they will stay. And this produces a moral quandary a lot of times for the people who are intervening. And when I would interview them, the aid workers, they would say, oh, it would be great if they stayed, and how can we keep our services running if we don't have our Haitian partners? But they would always say something like, but I don't blame them. I would leave too if I were them, and I understand, they want their kids to have a better opportunity than they've had. So how do people negotiate this essentially as a moral question, right? Incentives around staying or leaving, either when you're in relationship with someone else, I want you to stay in Haiti, or oneself. People in Haiti are known for being very both proud and ashamed of their country. They're proud of accomplishments, for example, Haiti being the first black republic, the only successful slave revolution in human history, and the second free country in the Americas. At the same time, they're very well aware of their position in the world today. And so even being Haitian at times is a source of frustration and shame. So these were some of the ambivalences that I was looking at that aren't just in the medical realm. They're taking place in other fields as well. Oh, so you will be missing to us. We will miss you, literally. Yeah, we will miss you. Huh. And there was a lot of joking at this party. I remember there were, maybe about 24 people who were there at the time, and they were all joking about whether or not she would come back, whether or not she would stay in France. And then, of course, the countries that they emigrate to, specifically the U.S. and France, have been in colonial or occupation relationships with Haiti. And so there's that additional complication as well, right? I mean, France was Haiti's colonial overlord in a sense, and they identify as the descendants of slaves of the French, and now to be in a position where they have to go to France in order to have a viable future is a very difficult position to be in. One of the reasons I became so interested in Haitian health professionals is because it's a very different image than what we usually see about international aid, global health, and Haiti. We're much more used to seeing pictures like this. The next 3 photos are all photos that I've collected from the internet after the earthquake and during the cholera epidemic. And these images are designed and based, in my mind, around what I call a humanitarian dyad. So you have a donor and you have a recipient. And the most compelling images are the ones where there's a very big distance between the two of them. So the distance can be in size, it can be in age, it can be in gender, it can be in race. But these images circulate, and they're what we're used to seeing in newspapers and on television and in stories about what humanitarian activities look like. So having a group of intermediaries, and whether it be in Haiti or elsewhere around the world, interrupts this picture. And this is part of why I think these clinicians that I'd been interviewing were invisible. We rarely see images of health professionals in Haiti. We see a lot more of patients and of people in misery, and then of saviors who come in to help them. Part of the challenge, again, of having intermediaries is that as opposed to directly giving aid to what you've identified as a worthy recipient or a victim, you are now working with another source of authority. And there's a lot of language around working with these intermediaries. For example, the language of corruption comes up a lot, the idea that aid is not really being channeled honestly, the way I talked about. There are a lot of talk about government structures, administrative structures. And at the same time, there's also a move towards partnering with these very structures as a way of ensuring sustainability, and because the feasibility of having people go down and do clinical work for 30 or 40 years as a stretch in places like Haiti, like the nuns and priests used to do, simply doesn't appear as a viable option in terms of contemporary global health projects. The challenges, again, of working with intermediaries became very visible in Haiti after the earthquake. This is the Ministry of Health before and after. How do you work with intermediaries who want to emigrate, who do not have a lot of their own resources and infrastructure? Sometimes it gets talked about as the capacity to absorb aid. When you have very rapid government changeover, it's a very big challenge. This is something that Paul Farmer has talked about as well. He has said that if he were to do over what he had done, he would have partnered with the government. I think that's easy to say today, but in the period where he started working in Haiti in the mid-'80s, you had one period of 3 years where you had 9 successive governments. And so I don't think it was even feasible for Partners in Health at the time to partner with the government, because they could be military coups, they could be gone 2 weeks after, they were not considered legitimate governments because they were not the result of elections. In Haiti, surprisingly enough, in the last, let's see, so since 1995 to today, that's how many years? 18 years, there's been only 1.5 years of transitional or illegitimate government, right? So 1.5 out of 18 for Haiti really isn't bad. More than 16 years of consecutively elected government makes it, in some ways, a more appealing partner than had existed before. But the future there is very uncertain, both in terms of specifically the Ministry of Health, but also in terms of the government structures on the whole. Just to tie this up and finish a little bit talking about global health education, I mentioned that these programs have really flourished in the last 15 years. And global health, as you may have seen, is very difficult to define, and there's no single accepted definition. But one word that keeps coming up is that it's interdisciplinary, right? Global health is not just clinical medicine, it's also epidemiology, public health, social sciences, architecture, engineering, information technology. But then again, this is part of what makes it so difficult to define, right? What isn't global health if all of these things are part of global health? Then you have people who are working in North America who constantly have to justify that what they're doing is global health as well, right? Because we know that Lesotho is global health, but is Sweden global health? Is an intervention in Denmark going to be considered global health? Or in Japan? In Japan, yes, if there's a tsunami or a nuclear disaster, but under other conditions, global health has often come to be a code word, again, for sub-Saharan Africa and then certain parts of Latin America and Asia. Working in an interdisciplinary setting, you also have a lot of jostling, I would say, or struggling for whose priorities and values are going to get heard, and who is going to be deciding at the end of the day what shows up in the global health curriculum. So my current study is doing research on global health training at UCSF, looking at what's actually being taught. The program has now existed for 5 years. It was the first master's in global health in North America. And they now have a cohort of 42 students. So it's become a relatively large program quickly, and they're going to keep expanding. But when I go to their courses, all of these fields and more are represented. And it's very interesting to see how the pedagogy and the curriculum get designed in a program that's very short, that's a 1-year program. Being influenced quite a bit from medicine, you have the idea of global health competencies, which are emerging, and people trying to define what are global health competencies. And these are even harder to identify, I think, than global health itself. The American Association of the APHA, American Public Health Association, has proposed 7 competencies for global health. And one of them has been partnership, the idea that partnership is a competency. And as an anthropologist, this is something that I find fascinating, because these partnerships really are human relationships and institutional relationships, oftentimes between North American universities like Stanford and individuals, institutions, hospitals, and universities in the global South. So how do you teach these partnerships, and what's considered a successful partnership? In terms of global health education, there are a few of us in medical anthropology who are starting to look at this as a topic of research. However, a lot of us have been recruited to teach in the global health courses. Some of us have been responsible for starting global health programs as initiators or participants, otherwise as supporters or facilitators. You also have a small but growing critique from medical anthropologists of how global health is carried out, whose priorities really are being highlighted and whose interests are being served in global health training today. You have people who are observing and as well researching what is happening. Because it is such a new phenomenon, and because it is so different in many ways from the ways in which people used to learn how to intervene when they were abroad. A lot of times there would be no formal training. They would show up at a field site and learn in kind of informal mentorships from people who had been there for a long time. Now the idea is that global health is something to be taught in a structured way before people even leave their country. So I'd be interested in hearing your perspectives around this as well. And I think I'll stop there. I'd be happy to answer any questions or hear any comments that you might have. Thank you.
Did you have any negative influence from the government? Who was the government at that time? Was that Duvalier? Was that Aristide?
When I was there, it was during the second presidency of René Préval, and I had absolutely no problems with the Ministry of Health, who were aware of what I was doing. I got official permissions from both the hospital and from the branch of the Ministry of Health at the time.
So there was no tutumaku?
No. I was very fortunate. I did my doctoral fieldwork between 2007 and 2009, and I kind of wove in and out of 4 hurricanes, and food riots were in another part of the country, and the earthquake happened 6 months after I left. So these were all things that I was profoundly kind of touched by as a person and someone who cares about Haiti, but my research went off very smoothly while I was there. So, yeah. Yeah.
So when it comes to, you talked about like individuals going to foreign countries or groups going, what do you think is the most ideal setup between North American individuals who are interested in going and developing countries? Should there be one organization that's a sponsor or a partner with a country, or should we say the way we are, where I can sign up to go and help people on my own? Or
Yeah. It's really hard, and in my mind, there's no easy answer for this, because I saw so many different models. So, for example, at the hospital where I was, you had people who would come in and do orthopedic surgeries for a week. And this is fairly common through Haiti, orthopedic surgeries, and also a lot of work around cleft palate, right? Groups like Smile Train, who will do a relatively brief intervention, and then go periodically, maybe from 1 year. So the orthopedics group, they counted their success in the number of people that they saw, right? So they said, all right, this year we operated on 37 patients. Let's try to beat that next time, right? That's really what their measure of success was. And when they were there, they really took over the OR in the hospital. They brought all their own staff, all their own equipment, and they kind of took over the OR for that week, and they really had it going. I mean, 18, 19 hours a day. I mean, it was pretty impressive, right? And so you had critics of this model saying, you know, you're completely sidestepping all of the Haitian staff who's here most of the time. You don't speak the language. You're leaving cases for follow-up for Haitian, staff who, after you leave, are going to have to deal with, the cases that you've left behind. And there was a lot of critique of this. At the same time, they were, helping people walk who had not been able to walk for 3 or 4 years. And I couldn't be in a position to say, well, ma'am, you can walk and now, take care of your family and your kids, but that was actually bad aid, and they shouldn't have done that, and it's not good, it's undermining a system. So it depends a lot on what your end goal is. I mean, one thing that I push a lot, of course, because of my research and because I saw that they tended to get sidestepped so much, is what are health professionals in the area where you are going, what kind of relationships do you have with them? And people who talk about kind of roadblocks or administrative bureaucracy or things like that, I think of them sometimes as being breaks that are for everybody's own good, right? Things that look like red tape. I think it's important to ask, well, why is that red tape there, and whose interest is it if this slows down a little bit? I mean, there was a lot of critique and aid in Haiti, for example, that put Haitian doctors out of business. After the earthquake, there was so much aid that was being given that a lot of the Haitian physicians said, we have to close down. We haven't seen patients in 6 months. All of the aid workers are there. And we were so glad that they were there at the beginning because of the trauma cases, but they're still there now. We have to shut down our practices, and they're probably going to leave in a year and a half, and then by that point we'll be in Florida, right? So I think always getting that kind of back picture and going with a lot of doubt, which is very uncomfortable, but the best groups that I saw who were there were very uncomfortable with everything that they did. And that meant also that they were thoughtful and that people respected them. People who were going with so much zeal and were like, we're going to do this and we're going to get this done, we're going to get this done, a lot of times they would just create problems and barrel through it. It doesn't mean not to be persistent, but it means to call yourself into question quite a bit and to be in dialogue, again, with people who are saying, wait, why are you doing this? And really, what's going on here? And to be willing to engage with those people. Because patients in settings like this are not going to do that. They're going to say, you are an angel, thank you so much for coming, you have given us what no one else has. Makes you feel great, but your intervention is going to risk going out of control if all you get is approval from the patients.
The Israelis had a good model for something like that. They would go in and help and bring equipment. They would also train side by side with the Haitians. So when they left better than when they came.
Yes. I may annoy you with a bad anecdote about the Israeli aid in this setting. The hospital where I was at, and the Israeli presence was extremely appreciated. But there was this, I'm not making this up, there was a situation where the Israeli government donated an emergency trauma unit to the main hospital in Port-au-Prince, who said, we don't have any room for this, we can't put it anywhere, send it to this hospital in Cape Haitian, because the Israelis wouldn't take it back. It was already on its way there in a boat. And so the director of this hospital found out that there was an Israeli critical care unit that was coming to his hospital. He found it out from a newspaper that an American partner organization sent him, saying, oh, we didn't realize you were getting a critical care unit. He said, neither did I. And it was on his way up there, and then he had to manage it. Today it's actually proven to be a good resource for the hospital, but something happened in that communication, and this is not just about the Israeli government. This is about any government who, when they have something to give, a lot of times will push to give it. And as well, people in Haiti will never say no to aid, hardly ever. You never see aid refusals, and that's something else that I discuss. Why is it that people who are in a position to be receiving resources will not refuse them, even if they don't want them, even if it's going to cause more problems for them? There's a couple things. Part of it's keeping the channel open, making sure that the donor relationship is still there in case something good does show up, or just being resourceful, like, sure, we'll take a broken ambulance because you never know, it might have parts that we can use on the other thing that we have here, and managing it that way. But I think it's also a good sign if people are refusing what you're offering, because it means that they trust that you're not going to abandon them.
Do you have any interesting anecdotes concerning alternative medicine, considering that Haiti is the home office for voodoo?
Uh-huh. So the literature on medical pluralism in Haiti is very rich, fortunately. There's some really nice studies that have been done looking at what people go to for what conditions. And a lot of times, I mean, biomedicine has been in Haiti or Western medicine first, allopathic medicine, has been there since the 1600s. So this is not something that's new for them or that's being imposed on them or that they're unfamiliar with. They're very familiar with biomedical treatments. They're not afraid of this as a medical system that is foreign to them. But you will see a lot of times people start with home remedies because they're available and they're cheap. And so that's secular leaf use. It's plant, drinking a tea for a stomach ache or for a headache or something that's not considered to be too severe. For more serious things, if they persist, they will go to a clinic, a dispensary, if the leaves haven't worked. And a lot of times people will turn to spiritual remedies, not just voodoo, but also Protestant Christian healing, charismatic Catholic healing, in cases where biomedicine has not helped them. So you see either sudden unexplainable illness or people with chronic conditions, chronic pain. The rates of diabetes in Haiti are exploding. It's very, very frightening to see what's happening with that. And other kind of chronic conditions that people will turn to either after or alongside biomedicine, but not necessarily in contradiction to it. Yeah.
What's the status of like the wireless infrastructure?
Of the what, sorry?
Wireless infrastructure. Is there any, cell
Wireless.
phones, things like that, communication networks?
Cell phone coverage is about for 98% of the country, so it's actually very, very
That's
good.
good.
They did a lot like in sub-Saharan Africa where because there's no poles and actual physical wires, the companies build their antennas, and so cell phones are very common. Wireless internet is starting to improve. Are you talking about in terms of access for medical training? Or?
Yeah. Or treatment or evaluation or...
Yeah, it's starting, and so this hospital now has a teleconference center where they have people who are giving lectures from the U.S. and from Europe regularly. That's changing a lot. You also have new patterns of data collection, which is interesting, with people using their cell phones, community health workers to report cases and to be able to. So all the issues around coordination and communication have changed vastly. Cell phones really started to pick up in Haiti in 2005. So this is also a huge development in places like this.
What are your thoughts on the extent to which all this private aid is sort of forcing the governmental infrastructure to not develop the way it ought to?
Yeah, it's
is it stuff that the outside groups are providing that the government just couldn't provide, or are the groups filling a hole that maybe the government would be developing if they were not there?
I think you can look at it both ways. In terms of international intervention, I mean, one thing to keep in mind is not all of it is private. A lot of this is public governmental. So USAID, the Cuban government, the French National Development Agency, CEDA from Canada, are all very present. So we talk a lot about NGOs in Haiti, but I think it's important also to keep in mind that government aid is very, very prominent there. And they work through NGOs, both Haitian and foreign NGOs. But since the 1980s, effectively, the number of NGOs in Haiti, it's estimated to be somewhere between 3,000 and 5,000. Nobody really knows. The number is very high. And, ranging in scope, right? The Catholic Church is an NGO, technically, and then I can be an NGO if I want to, right? But in terms of has it been undermining the government, I think a lot of times it's been recognized that there's a parallel system that's been created, right? And patients do not have a positive view of Haitian government facilities or of the state in general, and people will complain a lot about the state. At the same time, all of the employees in the public hospital that I talked to, their paycheck could be 9, 12 months late, and they say, we're going to get it anyway. And I said, why? And they said, it's because it's the state. It'll come through. It will come through no matter what. So there's this kind of ambivalent relationship, right? And to doubt your own state is a very complicated, I think it's something that happens in a lot of parts of the world, but in Haiti, there's really been an actual opposition between the state and the Haitian nation. And so you have an increasing turn towards groups like Partners in Health and some of the other groups that I've been researching who said, we're going to partner with the government. Partners in Health, that big hospital that they just built in the Central Plateau, Haiti's second biggest hospital, all solar, really amazing. They said 10 years, that's going to the Haitian government. That's a big risk they're taking because no one knows what that government's going to look like in 10 years. And at the same time, it's something that they're committed to because they're committed to public health. So, yeah.
Is it possible to transfer difficult patients to American hospitals?
Yes, there are certain groups who do that. So the University of Miami, for example, has like a medevac situation where they will do that. Harvard's been doing the same thing as well. It's extremely expensive, and there's arguments around, of course, cost effectiveness and the money for that. Could it be used for other things? But it does happen. And people who have the means in Haiti, and this is also part of the problem, people who have the money to get treatment elsewhere go to the Dominican Republic to get medical services or to the United States. And so you don't have a lot of resources of just middle class or upper class Haitians that are going back into the country's system. Yeah. And they say we shot ourselves in the foot, you know, because if we are in a serious car accident and we can't get to Santo Domingo, we die because the area that we're at, you know, the last hospital closed down a few years back, and you know, so that decision to go abroad for medical services is not without a lot of ambivalence and a lot of, you know.
Pierre, during your time in Haiti, have you observed any successful training of residents in Haiti from a foreign source?
Mm-hmm. So there's a few, actually. One of the groups that I focused on was a group called Competencies, which is a small group out of Portland, Maine. And they did an interesting thing when they started. They'd all been doing medical missions around the world, Latin America and Africa, and they started working in Haiti saying, you know what, we're tired of going and just giving shots and going back and giving vitamins every year. We really want to do something different. So their commitment was to do no clinical services and to work only with the public system. And when they started, everyone was like, what are you doing? You know, the USAID, who was giving them part of their funding, said, we're not going to keep funding you because you can't give us any numbers about, you know, what you're actually doing. They were doing training and infrastructure and helping, you know, with the administration and just kind of being a partner in some ways. But a lot of what they were doing was building trust over those years. But for example, their residency program, so what they do is they supplement the salary of 2 Haitian attendings. Before that program started, there was just 1 pediatrics resident in this entire hospital. Again, with a catchment area of 1 million people, you know, like this is just not very much. And now they've gotten it up to about 20 by hiring 2 attendings who are technically state employees but who have their salaries supplemented by this NGO. People will come down from time to time to do lectures and give support materials. But essentially, they have created the conditions for Haitians to be training Haitians and for this residency to take place on their own. Now, the residents are giving good quality care in the hospital, getting good training. Some of them are staying in Haiti for a few years, but most of them are leaving, and that's something that they just can't do anything about.
And how about foreign doctors training local doctors?
Yeah, so that will happen more sporadically. It'll happen kind of with a week-long visit or 2 weeks, and it's very difficult. It's very difficult to do for language, for not knowing what equipment is there. Haitian residents would complain a lot of the time. They say these people come in, you know, not specifically the main group, but generally say, you know, they teach us about equipment that we don't have here and we're not using, or they teach us about medications that we don't have access to. So what they're training us for is actually not that relevant to what we need for our practice here. They still wanted to know it because they were hoping that they would be somewhere like Maine eventually and they would have a head start, or they were, you know, all getting ready to take USMLEs and you know, so they wouldn't say no to it, but at the same time, it would, you know, and the instructors coming in would say sometimes, they're like, I don't really know what I'm in a position to teach here, you know, because I'm not familiar with a lot of the medical conditions that they were facing every day, and B, I don't know what they have to work with. So, yeah.
Dr. Messner and Joanna, I'd be curious to hear what your experiences in Zimbabwe were compared to this. You know, was it similar? Were you just coming, you know, dropping in and doing cases and leaving, or were you doing more training, or kind of a hybrid of the two?
So Joanne hasn't been to Zimbabwe yet.
Oh, sorry.
No. Paula went. Paula went.
Paula,
Unfortunately,
yeah.
Paula's not here this year. So the goal with Zimbabwe, or in my opinion, from doing a number of different things in different countries, has been the best. The only way to make any kind of lasting impact is to train the people there. And I actually am very much against these ones where you go in and you do 50 cases in a week and then you leave, especially when you take your equipment in and then you take it out.
Yeah.
Because I think that is incredibly demoralizing for the people there. If you're going to take equipment in, then ideally you leave it there for them to use, ideally. I mean, it doesn't always work that way, but And in Zimbabwe, it is very interesting. They're up to, so they have 14 million people in the country, and they're up to now 7 ENTs for the country, which they thought was great. I mean, they thought 7 was, just spectacular. 6 of them are in Harare, one town, and there's one other guy in one other town, and then the rest of the country has no one. And where the exchange that we've been doing is actually at the medical school in Harare there. And it's a fascinating society because it was colonized by the British. So in many things, it's very British, meaning the medical system is very hierarchical. I mean, surprisingly so hierarchical. Where, your title is everything, and the professor is what they say goes, regardless of what the facts are. So that's interesting. The amount of corruption is truly impressive. Corruption in the hospital. The government gives so much money to the public hospital to run, but they won't open their books for people to see because the head of the hospital can then siphon off tons of money for other stuff. And so they, a lot of debate among people. They can't keep the lights on because, the light bill hasn't been paid, and yet there's plenty of money out there. It's just being siphoned off elsewhere. So a lot of corruption. And what I think is most difficult, and the same thing that you said, is that when I go to some of these places, you want to help teach them the stuff that's pertinent to them. Although I learn just as much as I always teach every time, because their diseases they face and the extent of their disease is so different than ours, right? I mean, because you want to see head and neck cancer, go to Zimbabwe for a little while. But what is really hard, I think, and I don't know if you have any ideas on it, is in some of these places the culture is, oh well, they're poor, they don't have money, they're going to die. Stuff that is easily curable, kids coming in with papillomas in their larynx. I mean, that may not be easy to cure, but can certainly be treated. But the sort of approach is very lackadaisical approach to life in some ways, what I would consider, that I found hard to do. Anyway, that's a random thoughts on.
It's been a big debate, actually, in medical anthropology, the question around fatalism and people's approach to life and death in situations like this, and what they will manifest in terms of what they're expecting, what they think should happen, what they know will happen. And it's very interesting because expressions of grief will be very different. How people will joke about death and medical humor. I mean, there's a lot of literature about that, both in North America and also in other parts of the world. And yeah, it's something that's generated a lot of debate in terms of how people are approaching things that could be curable or things that shouldn't be happening the way that they are. I would say what I've seen the most is people in Haiti are constantly confronting the way they know things should be and the way things are every day. And they have to kind of go back and forth between the two of those in terms of what they aspire to and what they idealize and what they wish things were like and what they know it will be like when they go to work the day after. So there's a lot of work that's been done on this in terms of psychology and emotion and kind of intersubjective, like different human relationships that are around things like tragedy, death, disease. Yeah.
Yeah, and the other thing in all these countries is they do not have, for the most part, Joanne's been working with one in Peru that does have it, but they do not have academic type medical centers where someone works full-time in an academic center. I mean, nowhere. Everybody may work a few hours in the morning in a public hospital so they can have the public appointment. But the reality is the salaries for the public hospital you can't live on. So you might earn $400 a month or something like that. And so they all have their private practices in the afternoon and evenings. And that is where their focus tends to be. So it's really hard to get people to focus more on training their residents and training and putting their energy into that when in fact it's a private practice that's
have you seen, for instance, when I went to Ukraine, you'd have the specialists localized in some big towns, and they would tend to hoard the cases to themselves, and they would have one resident with them that would not teach and want everybody to come and try to cluster around them.
So, I've heard Bill Free, when he would go to China, interestingly, would say there was a culture there where the professor would not, even if he had trainees around him, would not teach, because then you're training the competition. And that was a big deal. And I think that does happen more than we care to think it does at a lot of these places. Because why would you train your competition? And even in Zimbabwe, which is a very rich and poor country at the same time, incredible natural resources. They could just be, they are were the breadbasket before their economic difficulties for Africa. And they're in private practices there, they earn a lot more money than we earn here. So their docs there are earning, as much as several of us put together, or at least a few of us put together.
Who's paying them?
Oh, but if you have the money, so if you're in that 10% or less of the population that has money in Zimbabwe or many of these other countries, South American countries, you are very wealthy. And they'll pay, you want your neck dissection done? Great, $7,000 up front, cash on the table.
So why, this might be an obvious question, but is it primarily just the idea of pursuing a better quality of life that makes these doctors want to leave, or is it professional frustration with the system, or what would you say is the number one thing pushing them to want to leave? Because they're probably pretty idealistic people, went into medicine. Do they start thinking, I'm going to stay in Haiti, and then they get burnt out and leave, or what is sort of the career arc of your average medical resident?
No, my understanding, and I didn't talk to, for example, a lot of people in high school, and they go to medical school right out of high school, right? So it's an undergraduate medical degree. But my understanding, and part of what's going on here, is that every one of these medical residents had a first-degree relative abroad, either a sister, a brother, a parent, even a child. And I was told, and I can easily believe this, that as young people, they are kind of socialized to expect that they will leave, because that way they can provide for their family. So, when you were talking about the low salaries, here it's $200 a month that the medical residents are earning. And they know how much, their friends who graduated with them are earning overseas. And they would say things like, I can do so much more for my country and my family if I leave, because I can send money back and I can support, 10 cousins to go to school, and I can, make sure my parents get their health care, and I can send, my niece to medical school or nursing school, and I couldn't do any of that if I were here, right? So they see migration as a way to kind of improve even life in Haiti. But I would say, and a colleague of mine, Greg Beckett, anthropologist colleague, wrote about this, that the prevailing mood in Haiti is that the country has no future, which is very depressing. And imagine what it's like for them to live in there. But they will say things like, Haiti's died, Haiti's finished. We're not, the country does not have a viable future, either environmentally, politically, or socially. And so the idea is to get out while you can, right? But what I also found interesting is that the people who were in the worst situation, who were, not physicians or nurses, but people who were very, very poor, either living in rural areas or in urban slums, would say, we can't give up. We have to keep going. And they were the ones who would talk the most about hope and most about, what could happen, because I think they had the most to lose, because they know that if Haiti's done, they're going to be there kind of for the end of it. So they stay, as optimistic as they can. And there are a lot of signs for optimism in Haiti. I mean, it's been through a lot, and it will probably go through a lot more, but, it's still 10 million people, and they're not going to disappear tomorrow. So, it's fascinating to watch, and there are some positive developments, I think, that need to be highlighted as well. And part of it is the work of the folks who stay. One thing that I found fascinating, a Haitian physician, a friend of mine, visited me in Montreal, and we were spending time together, and she said, she's like, I like spending time with you more than my Haitian friends. And I said, why? And she said, because they make me feel like a failure because I stayed in Haiti. Like I wasn't good enough to get out. And they say to her, you know, why are you still there? You know, you could come here and specialize and do more in advance. And she's like, I didn't want to leave. And her rationale was really interesting. I was expecting that she would say something like, I want to stay for my people or my country. That's not at all what she said. I said, you know, why did you stay? And she said, I studied medicine. And if I go abroad, there's no guarantee that I could practice medicine. I did not study medicine to become a travel agent. I studied medicine to be a doctor. I'm going to stay here where I know that I can practice medicine. So her commitment was to her field and her discipline. You know, and whereas people from abroad, we may want to hear people talking about like being committed to a population or to strangers or to the poor, you know, her commitment was to her professional practice. And if that's what it takes to say, all right, well then, you know, stay, and how can we make things easier for you to stay and live out that? Because there are people who are benefiting, you know, by the fact that she stayed there.
We've got a couple medical interpreters that are physicians that were trained in Mexico in that case.
Yeah, which is really, it must be very interesting for them to be now in this new intermediary
Great
position. And
I tell you, those physicians that are interpreters, they're fantastic because they know exactly what you're trying to say.
Oh, wow.
Well, thank you very much.
Thank you so
Thank
much.
you. Thank you.